Thank you very much. I want to thank the organizers, Dr. Saad, Dr. Nadeem, and everybody who's involved in organizing this wonderful meeting. Thank you for the invitation, and thank you for actually taking the lead in getting this community together to start a local and regional society of radiation oncology. I wish you the best in the future, and we are ready to help. My talk today is on optimal use of androgen deprivation therapy and radiation therapy in prostate cancer. It is a long topic, and I know we are limited to 20 minutes. I will try to get the message across in as quickly as possible, and if there's a section that I cannot cover, we'll leave it for discussion or for questions. So this is the outline. I will review some of the basics. Why we are using ADT with RT. I think now it's becoming second nature. Everybody is using it, but sometimes we have to think why we are using it. How is our patient selection? How we select patients for ADT and radiation? The timing of ADT and radiation. When to start radiation when patient is on ADT is very important. How long to use ADT? And does ADT work with the use of high dose and dose escalation radiation therapy? Some people are challenging this concept, saying if we use high dose radiation, maybe we don't need ADT. And I will close on some of our own work on predictors of response and prognosis. This is an old slide from Anthony Zeitman from Mass General. Very beautiful and classic laboratory work using animals with xenografted tumors with prostate cancer, testing the value of radiation therapy with or without ADT. Using the TCD50, which is tumor control probability for controlling 50% of the mice xenografted. This is the radiation therapy alone, and this is the animals treated with neoadjuvant adrenaline suppression and radiation. Look at the dose reduction that you need to get the same amount of tumor controlled from about 80 gray to 40 gray, almost half. In between, you have different androgen, adjuvant androgen suppression or androgen independent, and we will talk about it later. Similar study was done at MD Anderson by Alan Pollack at the same time, showing the value of doing ADT alone for xenografted prostate cancer, hormone-sensitive tumors to animals, to basically laboratory animals, and using radiation in different days after, and they can demonstrate that you can have an increase by 7 times the amount of apoptosis in these tumors by combining the androgen deprivation and radiation therapy. And this is the curve for radiation alone. Radiation alone, androgen deprivation alone, and look at the synergy of two together. So there is clearly preclinical data suggesting and indicating and actually demonstrating that this combination is very successful. Now we have also the clinical data, and all of us clinicians know all these trials that have been published over the years since the 80s, using combined hormone ablation or at ADT and radiotherapy. And this is the meta-analysis of these trials showing every single endpoints: biochemical failure, local control, distant control, and overall survival are improved by the combination of androgen deprivation therapy and radiation therapy. I want you to look at distant control here. How come that combining a systemic agent with a local agent, we are improving distant control? And this is something we need to keep in mind. Studies have shown that you can improve distant control either because you are improving local control and those tumors are not recurring and not receding, or maybe, or this ADT is contributing distantly, and this is a very important factor. Patient selection, we have known from day one that not every patient needs combined therapy. This is the RTOG famous trial looking at low risk and intermediate risk, and definitely demonstrating that the low risk patients do not benefit from the combination of both ADT and radiation therapy, whereas the intermediate risk are benefiting from the combination. So for low risk, there's no need. And some post-hoc analysis of this trial actually have been able to demonstrate that the benefit is actually restricted to the unfavorable intermediate risk. And this is something that's actually gaining ground in our practice. We are basically more going with ADT for the unfavorable intermediate patients. Timing of initiation of radiation therapy for patients who are on ADT is very important. When a patient is on ADT, when to start radiation, and we have a lot of data. This is a retrospective study from MD Anderson showing that if you treat patients with the PSA less than 0.5 versus more than 0.5, you have a difference in outcome. This is retrospective, probably a lot of confounding variables, but this is what they found. And similar studies, similar outcome or similar results were found in the Memorial study published around the same time. And here the cutoff was 0.3. So for years, we were kind of considering treating patients on ADT with radiation when the PSA drops below 0.5 or 0.3. This has been a practice based on 2 retrospective studies, but coming from big major institutions. But when you look at the data, looking at this question in a randomized fashion, we have 4 trials. The most important one of them is the RTOG 9110. Here they look not at nadir PSA, but look at duration of neoadjuvant treatment, 2 months versus 7, 4 versus 8, 3 versus 8, no difference. So extending the neoadjuvant in these trials was not really bring any benefit. And the drug trial, there was some benefit for 5 more than 2 months. There is no PSA data for these trials, only duration. And this is very important to keep in mind. Now, if you look more into the subjects, there are some meta-analysis looking at this question. And this meta-analysis looked at the extension of adrenal ablation, whether it is extended before radiation therapy or extended after radiation therapy. And they found, and this is a very interesting result, that if you extend the neoadjuvant ADT, will not bring any benefit. But if you extend the ADT after radiation, there is a benefit on metastasis-free survival and on overall survival. This is very important. Extension of ADT before did not improve. And there's another recently published meta-analysis around the same subjects showing that concurrent and adjuvant ADT, concurrent with radiation adjuvant, is superior to neoadjuvant and concurrent. All this is going against a little bit of our current practice. We still do a lot of neoadjuvant and then follow with radiation. I think this data is here to indicate that actually maybe we should think of initiating radiation therapy early and extending the ADT beyond after radiation therapy is done. The second, this is actually looking at radiation to the prostate and pelvis. I'll pass on this. But there was a question, this question was actually tested in a single randomized trial by Canadian investigators. They looked at 4 months of ADT neoadjuvant followed by radiation with ADT, total 6 months, or 2 months and radiation followed by adjuvant 4 months. And this again goes in the same direction, no significant difference, but concurrent adjuvant was superior to neoadjuvant and concurrent, no difference in overall survival. So all this data is actually pointing to the direction that don't spend too much time upfront with ADT, move a little bit beyond radiation therapy, go radiation therapy first, and then extend whatever you want to extend beyond it. Optimal duration of ADT, and here this is very important questions. We have lived all our careers treating patients with extended duration for which they have high risk. This is from the 9202 RTOG trial. This is a classic trial showing that this is a 10-year follow-up showing a benefit on almost all endpoints using the long-term ADT for patients who have high-risk disease. Similar results with the URTC trial, looking at 6 months versus 36 months. And here, this trial has actually combined a lot of high-risk patients. And you can see here, there's a benefit on overall mortality and prostate-specific mortality with the extension of ADT. But this is too much, 3 years, and 2 years is too much. And the Canadian have looked at possibility of reducing it to 18 months. And the 18 months, this is the Canadian trial again, looking at 18 versus 36 months. There was a borderline trend for a benefit for the extended 36 but no benefit on overall survival. Nowadays, in our practice, we all now use the 18 months for those patients because 36 months is very heavy and it's very difficult. And there's, according to this long-term data from this trial, there is no benefit in overall survival. Dose escalation and androgen ablation. This is a very important topic, as I mentioned earlier. Some investigators have said if you can deliver high dose of radiation, maybe you don't need the ADT. We have a very important trial. This is a Canadian trial looking at 6 months versus with radiation 70, 76, or 76 alone. And the winner is actually the combined 76 plus ADT, and the 76 gray alone is inferior in biochemical free survival. Overall survival remains the same. This is very important to keep in mind. The RC trial, they looked at different design, looking at short-term and radiation at 70, 74, 78, compared to radiation alone, 70, 74, and 78. Fast forward, let's look at the overall data. This is showing that whenever we combine with androgen ablation, we have a better biochemical free survival. And the optimal combination is 74 gray and androgen ablation. After 74, 78 did not bring additional biochemical control. So this is the RTC trial indicating that you can get improvement with the combination of high dose and androgen ablation. And the R2G have recently published the results of their intermediate risk patients. And they found, again, biochemical free survival improved with the addition of high dose and ADT, but overall survival not different. So always keep in mind, you can improve biochemical free survival because those patients are amenable to salvage. The overall survival is not improved. So finally, I would just bring you some information about some research we did on predictors of response. In our study that we did in combination, in collaboration, with the King Hussein investigators, we had 375 patients with intermediate risk and high risk patients, prostate cancer patients. We found that if we achieve a PSA nadir, bottom PSA level of less than 0.06, there's a difference in outcome. And we were not alone because additional studies came afterward. This is from Turkey, showing that there's improvement with 0.06 cutoff. And what we have actually used this, and later on, we analyzed patients who achieved the 0.06, and they were high-risk patients. And we looked at their number of months that they received androgen deprivation. And we found actually those who are in the favorable group who have been very responsive, you don't need more than 12 months because beyond 12 months, there is no difference in their outcome. For those who do not achieve the 0.06 nadir cutoff points, you need at least 18 months. In addition, and this is my last slide, when you look at the very, very favorable high-risk patients, these are high-risk patients, and they have achieved nadir PSA less than 0.06, and they achieved it fast within 6 months. Those patients, according to ours, this is a small group, according to our analysis, there is no difference in their outcome, whether we give them 9 months, 12 months, 18 months, or 24 months. This is hypothesis generating data. Is not to indicate this is true. This is actually very provocative and very stimulating, and additional data is needed to know if this will hold or not. So in conclusion, ADT and radiation therapy, low-risk patients do not need ADT. Intermediate risk patients and favorable need ADT, and they benefit from it. High-risk patients benefit from longer adjuvant ADT, and 1.6 years seems sufficient. Most benefit from ADT, I hope I demonstrated to you, derived from the adjuvant part, not from the neoadjuvant part. And short-term androgen ablation with radiation high dose is beneficial on biochemical free survival, and response to therapy as determined by nadir PSA or time to nadir could be potentially used to gauge duration of ADT, but more data is needed. And thank you very much for your attention.